Okay, we are officially recording. This is the Unit 6, Class 3 Zoom. So let me just get up here and we will get started. Okay, so as I said, Unit 6, Class 3 Zoom. As we go through, again, have your pre-class handouts ready to go because they'll be very helpful for taking notes. We are going to be covering quite a bit this class because this is kind of the big prep for the video case study, the Susie Phillips case study, which is really a nice way to really kind of tie all this content together. But you have to have some prep for it in order to get the most out of the video where Susie has come and talked to a previous class. Okay, so moving on here, let's go ahead and start with today's quiz. Looking at the scores overall, people did fairly well. It was just basic terminology related to oncology. So angiogenesis is the ability of cancer cells to actually stimulate the growth of their own blood vessels and their own blood supply. This is actually, it's really fascinating when you think about it. And it's also one of the reasons why patients who have cancer tend to lose weight. They have unexpected or not really, not unexpected, but they're not trying to lose weight. This is part of the disease process. The metabolism rate of the cancer cells is so much higher than a typical normal cell. So between that and between the growth of these new blood vessels, essentially giving itself its own blood supply, it's using up a lot of the patient's energy and the patient's calories, which is why they have that unexplained weight loss. So that's angiogenesis, the ability of cancer cells to create their own blood supply. Nadir refers to the point after chemotherapy where the blood cell counts are the lowest. And typically when we're talking about a nadir, we're referring to the white blood cell count. So the lifespan of a white blood cell is approximately 10 to 14 days. So what that means is about 10 to 14 days after receiving a chemotherapy treatment, that is the time period when the patient's white blood cell count will be at its lowest. And they're most at risk to contract a very deadly infection. So when you hear the term nadir, that's what we're talking about. Xerostomia refers to dry mouth, dry mucous membranes, dry oral cavity. And we'll talk about that in relation to chemotherapy and how that can affect their overall nutrition. It can affect their overall hydration and pain control. Pancytopenia. This is a global term that actually covers three separate things that we're going to talk in depth about today. So pan refers to all, and cytopenia refers to low counts. And in this case, we're talking about low blood counts. So within pancytopenia, you also have anemia, which is your low red cells, hemoglobin, hematocrit, and we covered that in Unit 3. You have low white cells, which is your leukopenia, or if we're talking specifically about the neutrophils, that's neutropenia. And then you have thrombocytopenia, which is your low platelets. So we'll talk about all of those things separately, but the reality is that your patient that is receiving chemotherapy, and in many cases radiation therapy, depending on where the radiation is being directed at, will experience pancytopenia. Alopecia is the loss of hair. And typically when we talk about alopecia, we think about, the hair on our head, but it actually applies to body hair, eyelashes, eyebrows, everything. So when we talk about alopecia, we'll talk about it in relation to chemotherapy where it's systemic, but also in relation to radiation therapy where it's much more site specific, particularly with the external beam radiation. Mucositis is inflammation of the oral cavity. And we're going to talk about that, particularly in relation to chemotherapy. It would also apply if a patient's receiving radiation therapy to the head and neck area. But this can make eating and drinking very difficult, very painful. So it affects their nutritional status. It affects their hydration status. Brachytherapy is another term for internal radiation therapy, and we'll talk much more about that because there's some very special protocols that go along with that, but it's internal radiation therapy. A carcinogen is just simply a substance that is known to cause cancer or is thought to cause cancer. So, we know that cigarettes are carcinogens, particularly for lung cancer. A vesicant is a medication that is extremely caustic to the vessels, so it can cause a lot of irritation. And if that medication were to infiltrate with an IV infusion, it can literally cause necrosis of the tissue. Chemotherapy drugs as a whole are vesicants. And we'll talk about that and why we prefer to use central lines as opposed to peripheral lines to administer any type of intravenous chemotherapy. And finally, palliation just simply refers to moving away from cancer treatment for a cure or control per se. And now our focus is really on keeping the patient comfortable. So just some basic terminology that we'll be hitting as we talk about today. So go ahead and pull out your cancer ALT because we're going to actually go through the different boxes and take a look at what you have and make sure you're adding to it for things that I'm emphasizing. Because I know typically the ALTs, you're just jotting down a couple keywords, but there's some basic things that you really want to kind of understand. And it does relate to the accompanying worksheet for today's online class that you do need to complete because that is your class 4 prep for Monday. And you also need to complete that in order to access the case study. All right, there's release conditions set. So you have to do that in order to be able to watch the case study. So let's just start with the ALT. So pull that out so you can, grab some notes or whatever with that. So when we talk about cancer, before we even kind of go there, it's just good to have a basic understanding of the immune system. Just very basic. But when you think about it genetically, all the cells in your body are what we call self cells in the sense that they have specific receptors that say, okay, this is a Mrs. Klein cell. All right, so the body recognizes it. The immune system recognizes it as self. It's a friendly cell. When cells start developing cancer, or it becomes a cancer cell rather, the cell starts to mutate and it doesn't look like a self cell. Okay, it looks like a foreign cell. So a functioning immune system is constantly on surveillance for abnormal cells, okay? And it shoots first and asks questions later. An active immune system, if it sees something haywire, out of whack, its mission is to destroy it. So it's doing this active surveillance all the time. And when it finds potentially questionable cells, your immune system is going to destroy it. That's its purpose. Now, if you kind of think about that, as we get older, the immune system doesn't quite work as well as it did when it was younger. So you might get a couple of those rogue cancer cells that kind of slip by the immune system. That's why you tend to see higher rates of cancer as we progress in age, okay? The other thing when you think about the immune system, if it does what it does, if we're on immunosuppressants or if we have an autoimmune disorder that's attacking parts of the body, that's going to predispose an individual to cancer, again, just because the immune system is not working how it's supposed to. So those are some major risk factors when we think about for cancer, certainly age, autoimmune disease, any type of immunosuppressants. Those are 3 big ones. But anyway, getting back into the basic patho of cancer. When a cell mutates, it changes, and mutation happens because of exposure to a carcinogen, or some sort of external substance that causes that mutation. Could be UV light. It could be, radiation from, a nuclear power plant accident. It could be a virus that is associated with the development of certain types of cancer, Okay, so the mutation occurs on the cell. Now, just because there's a mutation there doesn't mean it's a full-fledged cancer cell. It doesn't mean it's going to cause cancer. We have mutations in our cells all the time. However, we also have processes in the body that are aimed at fixing those mutations. Okay, so when a mutation occurs, it really depends on a couple things. First of all, how extensive is the mutation, and where in the cell cycle is that particular cell when that mutation happens. Because when you think about the cell cycle, cells divide. Okay, cells divide. So when there's a mutation, a couple things can happen. One, the mutation can just be so severe, it damages the cell so much that the cell just can't survive on its own, okay, and it just dies. Second, the mutation can occur, but depending on where we're at in the cell cycle, our DNA, the RNA, is able to repair it before that cell then divides, okay? No harm, no foul. And third, that mutation persists, the cell divides, and now I have two mutated cells, okay? And the process repeats itself. What cancer is essentially a cluster, a group of cells that have uncontrolled growth, okay? I like to think of cancer cells as teenagers, okay? They have no limits. They continue to wreak havoc, they multiply, they don't have what we call contact inhibition. So they're growing all over other cells. They're growing in between other cells. Instead of the cell dividing into two, it divides into 6 or 3 or 5. It's just very haphazard and crazy. So that's really the underlying development of cancer and the pathophysiology. Now, that's a very basic thing. I went way more into depth than that in the pre-class capture. There's lots of different things that cause mutations, that cause cells to kind of go haywire. You know, there can be viruses, again, different types of carcinogens, chemicals in food. I mean, ultimately, we do not know all of the carcinogens that exist out there. But you just need to have a basic understanding of how cancer develops to kind of understand the rest of this entire class that we're talking about. All right, I see something in the chat box here, but for some reason my chat box isn't coming up. So we'll check that again in a little bit. I'm gonna move on to risk factors. And we kind of talked a little bit about this in relation to the immune system, but certainly risk factors age, as I mentioned before. You know, the older we get, the less our immune system functions up to par, and that's gonna put us at risk. Certainly, immunosuppressant drugs, as I mentioned before. Other risk factors, there are certain viruses and certain infections that are linked to specific types of cancer. For example, HPV is linked to cervical cancer. You know, hepatitis B and hep C are linked to liver cancer. I mean, that's, you know, pretty strongly correlated in the research there. We also have lifestyle risk factors. You know, we talked about skin cancer back in Unit 1, you know, laying out in the sun at the beach, laying in the tanning coffins, which are even worse, okay? You know, so things like that as well. You know, certainly smoking is going to be a direct risk factor for cancer, for lung cancer. Okay, so there's a lot of different things out there. For colorectal cancer, we know that diets that are low in fiber, that are high in fat, higher in red meat, those are risk factors that increase, you know, the incidence of colorectal cancer. You know, so there's some different things there. Genetics play a huge role. Many cancers have a genetic component, particularly your reproductive cancers, your breast cancers. There's also a strong family link in colorectal cancer. So, you know, obviously some of these things are modifiable, some are non-modifiable. As much as we can, you know, take action to try to reduce our risk, that's a good thing. But you can never completely eliminate the risk. And the reality is we are constantly exposed to different types of chemicals and substances on an everyday basis in food, in the plastic bottles that you're drinking out of, you know, water bottles, Powerade bottles. You know, there's a chemical that we know about, BPA now, BPA. that's been linked to cancer, just different chemicals. Those of you, when you're at clinical and you're at work and you're wiping off your stethoscope or you're wiping off any type of other equipment with those Sandy wipes, make sure you're wearing gloves, because if you read on those bottles, those are considered a carcinogen with repeated exposure. So you should be using gloves with those types of things. Your cleaning products, just any type of exposure with that, you know, trying to wear the personal protective equipment, and certainly good hand hygiene that goes along with that. So with those risk factors comes prevention and screening. And they call it prevention, but the reality is there's really no 100% way to prevent cancer. There's just not. We do have screening tools, and they're classified as what we call secondary prevention. The purpose of screening tools is to identify early on if there's a possibility of cancer. So we've talked about some of these before in the different units that we've done, particularly urinary, when we talked about prostate cancer, and we talked about the PSA level and the DRE, the digital rectal exam. Again, a screening test is not going to definitively diagnose cancer, okay? What it does is, if it's positive, it's raising a flag, like, hey, something's not right here, it needs to be investigated a little bit further. It might not be cancer, but these are things that we can very easily do to large numbers of the population that can then determine if this patient needs additional testing, additional diagnostic testing to figure out, do we have a cancer or do we have something else? So when we talk about prevention and screening, the big common ones that you want to be aware of, certainly the colonoscopy. We talked about that in Unit 4. Everyone should be having a colonoscopy by about age 50. This is for people with normal risk profile. If your patient has any sort of GI issues, Crohn's disease, ulcerative colitis, family history of colorectal cancer, stuff like that, they're going to be on a totally different screening schedule. I'm talking about the general public with a normal risk profile. Colonoscopy should start at age 50, and they're generally repeated every 5 to 10 years, as long as they were a normal colonoscopy, normal findings. If they find something abnormal, if they've removed polyps, they're going to repeat that colonoscopy in a much shorter time frame than that. But the colonoscopy should be starting at age 50. For our females, for the breast cancer screenings, mammography is used. So with mammography, again, the normal profile at this point is going to be starting at age 40. They don't want to start that earlier, because up until about age 40, the breast tissue is very, very dense, and it's difficult to discern, potential tumors just from regular dense breast tissue. And at that point, it's just not, when we look at the cost benefit ratio, it just would not be really effective as a screening tool for a large volume of people prior to age 40, because of things that would be missed. Okay, so again, normal risk profile, mammographies are going to start at age 40. Other things that we talked about in Unit 1 when we talked about skin cancer, your annual physical with your provider is a good time for that annual skin checkup, and really be looking to see, are there any skin changes? Are there an increase in moles? Are there changes in moles? Now, beyond that annual professional exam, patients that are high risk, and really all patients, should be taught to examine their skin at least monthly. I like to call it the mole patrol, but we're looking for changes. Go back to Unit 1, the ABCDE that we talked about with the moles: asymmetry, borders, color, diameter, and evolving. And looking for those changes. Certainly for our cervical cancer, when we talk about Pap testing, that is generally recommended to start at age 21 or earlier if the patient is sexually active. If they're not sexually active, age 21 is the recommended age. And that should be done. There's some different recommendations now, every 1 to 3 years, depending on what their risk factors are. But that pap testing, again, is looking at cervical cells under the microscope to see if they are changing in appearance, because cancer cells look different under the microscope as opposed to looking at a normal healthy cell. So certainly the pap testing. Let me skip back to the mammography. We talk about the mammography as an official screening tool, but you also think about things like breast self-exams, and that ties into what I was just about to talk about here, testicular self-exams. So those are both self-screening tools that patients should be taught. Again, they're not going to diagnose everything, but if they're doing these exams on a monthly basis, they are much more likely to pick up a change earlier rather than later when it's more pronounced. So those things are pretty important. Other things that focus on prevention, not so much screening, but prevention, thinking about stuff such as using sunscreen appropriately, and just making sure you're wearing clothing that keeps you covered, to try to avoid those UV lights. Okay, let me see if I can open the chat box now. Okay, here we go. All right, is the case study a graded assignment? I'm assuming you're referring to the video case study. It is not a graded assignment. However, it is very much a opportunity to really put these concepts together and really understand what this looks like for patient care and really seeing a patient in the flesh. The Hinkle interactive case studies, and there are 2 of them on the online class worksheet in preparation for the video case study. They go through and look at a patient profile. But when you're watching the Susie Phillips video case study, Susie came to campus and she spoke to a class about her experience, all the way from what she experienced, what made her initially seek out medical care, through the diagnosis, through the prognosis workup, through chemotherapy, surgery, radiation, the whole thing. So her story really helps solidify all this content and put it together in how it fits into patient care. So while it's not a graded assignment, it is highly, it's needed for you to do well in the exam, just point blank, to put it together. How often does a patient do a testicular self-exam? Those should be monthly, just like breast self-exam should be monthly. So the testicular self-exams, if you think back to testicular cancer, our population that has the highest rates of testicular cancer are going to be your adolescent and your young adult males. This is the one area of cancer that's totally different. We usually think about age as a big risk factor. Not so much with testicular cancer. It's the adolescents and the young adults. So when we talk about a testicular self-exam, the best time for them to do that is really in the shower, because the hot water kind of relaxes the tissue, relaxes all the muscles in the genital area. And actually, because of the heat, the scrotal sac will hang lower away from the body, which makes it easier to palpate the testicles. So internally, the testicles feel essentially like eggs, okay? Kind of like, you're making eggs, in the frying pan in the morning. That's what they're shaped like. And when you're palpating and feeling over the testicles, they should be that nice, smooth, egg-shaped feeling there. If you feel asymmetry, or you're feeling things that almost feel like a nodule, that indicates that there's a problem. And obviously we're symmetrical beings, so what you have on the right, you should have on the left. But again, this is really important as a self-screening tool, because think about the population that we're dealing with here. It's adolescents and young adult males. And let's face it, unless they are actively playing sports, those are the only people that absolutely have to have a physical every year because the state makes them. This particular population, they generally will not seek out assistance, at least not professional assistance, unless something is seriously wrong. So this is an area where we can really make a difference in educating the population, and really, you know, not to sound, not to sound awful, not to make a pun, but, you know, their well-being is really in their own hands, because I have known patients that have done testicular self-exams, and they were the ones that found something abnormal and sought help, and we were able to get them treated. And while fertility is not a huge priority for the patient per se, an adolescent male generally isn't, you know, worried about having babies, and they're really worried about not having babies at that point. That really is a big concern long term. So it is very important to identify that early so we can start early treatment. Now, coordinating that to the breast self-exam, that also should be done monthly. That does not need to be done in the shower, although that's a fine time to do it. But what is helpful for the females is because the breasts will change throughout the month based on where they are in their ovulation and menstruation cycle. So it is generally recommended for the breast self-exams for them to be about the same time every month. So if they're gonna do it the first day of their period every month, then that's what they wanna stick with. As opposed to, well, I'm gonna do it the 1st of this month, then the 7th of next month, and then the 15th. You wanna be consistent, because there are breast changes throughout the month, you know, as the body prepares for potential fertilization and pregnancy. And then, you know, when the egg's not fertilized, you know, it you know, kind of sheds all that and then starts the whole cycle over again. So just some things to kind of think about there. Okay, so I think we've handled that. I'm going to put the chat box back down. Do feel free to keep entering questions in as you have them. So we talked about prevention screening. So the next piece to kind of go to is really diagnosis and staging and grading. So what generally happens is during a screening test, something pops up as abnormal. So let's just use prostate cancer as an example. The patient's PSA is elevated. They've had that digital rectal exam. It kind of feels a little asymmetrical. Again, don't have the official diagnosis of cancer, but there's a red flag there that we need to move to the next stage. And the next stage is going to be biopsy. Okay, so the biopsy is where they go in and they take a piece of the tissue, and they definitively can tell if this is cancer. They look at it under the microscope, they do some testing, and without getting extremely technical, they will look at the characteristics of a cell. I mentioned before that a cancer cell, particularly as the cancer becomes more advanced, the cell is going to look more and more abnormal, and it's going to function more abnormal. Okay, so they're going to look at that, they're going to do that biopsy, and that's going to say, yes, this is cancer, or no, it's not. So once that biopsy is done and we have the definitive diagnosis that, okay, yes, this is cancer. Now that's a very superficial thing that I just talked about. When they talk about, you know, the genetic makeup of certain types of cancer, when they do that biopsy, today's technologies, they're mapping the gene sequence, and they're doing things like that with that biopsy sample as well. But once we have that diagnosis, now we look at the staging and grading piece, because the staging and the grading is going to determine what the patient's ultimate prognosis is, and it's also going to help guide treatment for the cancer. So what I'm going to talk about, and what I talked about in the pre-class capture, when we talk about staging and grading, I'm talking about the very basic principles of staging and grading. There are additional, more advanced ways to grade within particular types of cancer. You know, for example, prostate cancer, they get a Gleason score. It's very technical, but the overall concept of the staging and grading is based on these main principles, which is what I'm going to be covering. Because as a nurse generalist, you don't necessarily need to know about the Gleason score of the prostate cancer, but you need to know the difference of somebody with early stage prostate cancer versus stage 4 metastatic prostate cancer. And what does that mean in relation to their prognosis and their treatment? So I'm going to start with staging, and staging for solid tumors. okay, for solid tumors. This does not apply to your leukemia and it does not apply to your lymphoma, okay? Those are based on grading principles, which we'll get to in a minute. But for staging of solid cancers, solid tumor cancers, we use the TNM platform, okay? The T stands for tumor, the N stands for nodes, and the M stands for metastasis. So in relation to this T and the N, okay, they are going to be given a score of 0 to 4, okay? So it'll be anywhere from, T0, TIS, we'll talk about in situ here in a minute, up to T4, okay? And the same thing with the nodes. So what the T stands for, again, back on the tumor, that's gonna relate to the tumor size, okay? So the bigger the tumor, the higher the number. So if you kind of think about the TNM staging system, like mini golf, okay? If you're gonna have cancer, if you're gonna play mini golf, you wanna have a low number, okay? Just a good principle to keep in mind. So the bigger the cancer tumor, the bigger the number. And again, it can go up to 4. So if I'm looking at 2 different patients and patient A has a T2 and patient B has a T4, patient B's tumor is larger, okay? So the N stands for nodes, and it's referring to the lymph nodes, because what will happen with cancer as it continues to grow locally and the tumor gets bigger, it will also begin invading what we call regional tissue. So when cancer first starts to spread, it's going to spread to the immediate localized area. And then beyond that, when we start talking about metastasis, it gets into the lymph system, it gets into the blood system, the hematologic system, and you have distal spread. But initially you have local spread, and you think about your lymph nodes as part of your immune system. Well, the way they work, they're trying to get abnormal things, they're trying to get pathogens, abnormal cells, get them in there and destroy them. With cancer, that process becomes flawed. So when we look at the end part of the staging, we're looking to see, has the cancer moved to the nodes, to the regional nodes? And if so, how many of those regional nodes are involved? Okay, so again, just like the T, the tumor, we're going to assign a number for the N, and it can go anywhere from 0 to 4. Again, 0, I have no node involvement. 4, I have extensive node involvement. Obviously, again, the higher the number, the more extensive this disease process is. Okay, and then we're looking at metastasis, and we're looking to see, with Mets, has it metastasized distantly or has it not? And usually metastasis is going to occur because cancer cells have gone into the bloodstream, they've gotten into the lymph system, and they've essentially hitched a ride to a different place in the body. Now, what's interesting about metastasis, certain types of cancers tend to follow the same typical metastatic path. So that's one of the things that's helpful for the clinicians, because they can then kind of pursue and work the patient up for what is expected. For example, we know patients with prostate cancer, starts in the prostate, you're going to see it go into the inguinal nodes, you can see it affect the bladder, it's going to get into the pelvic rim, the pelvic bones, and then it travels up the spine into the brain. That's the typical path of a prostate cancer if it's left unchecked. So, same thing when you think about with breast cancer, okay? Well, it's in the breast, it's going to move regionally to the node. So that's why we look at the nodes in the axilla under the armpit. Colorectal cancer obviously starts in the colon. We look to see regional spread to the liver, pancreas, those types of organs, sometimes to the bladder. Uterine cancer tends to spread to the ovaries, into the bladder, into the bowel. So a lot of these cancers have a typical path that they're going to take. So when we look at that TNM, that staging, that's going to be really important. Now, the way to stage a patient, obviously we do the biopsy for the diagnosis, but the staging piece, they are going to have multiple scans and x-rays. Essentially, they're scanning their entire body to look and see where the cancer is present, where it may have spread to. Okay, so that's a process that takes several days. Sometimes it takes a couple weeks to get complete staging. Now, the grading piece kind of goes along with the biopsy a little bit. And I mentioned before how they look at the cells underneath the microscope. So grading, you can grade a cancer from grade 1 to grade 4. And again, the higher the number, the worse it is. Okay, so if you're going to have it, you want a lower number. So the difference between the grading is when you're looking at these cells underneath the microscope, they visually look different under the microscope. So in the lab, they do the staining of the cells and they look at them under the scope. And if you look at a normal liver cell, let's just use liver for example. You look at a normal liver cell and you look at a stage 1 liver cancer cell, they're going to look pretty similar. There's some differences that you can tell, but they still look pretty similar. If you compare a normal liver cell to a grade 4, if you didn't know that it was a liver cell, you might not even be able to tell that the original cell was a liver cell. So again, when we talk about cancer cells, they are abnormal both in appearance, but also in function. They start doing jobs that they were not meant to do. They start dividing more often than they are supposed to. And when they divide haphazardly, and it's not just one cell splitting into 2. So you have a lot of different things going on there. But that staging and grading piece is going to lay the foundation for how we treat this patient, what's going to be their plan. So getting into the medical treatment side, from a medical perspective, and we'll look at these all more in detail, chemo, radiation, and biologic therapy. And then you have the surgical side. So for many patients, this is a multimodal treatment. They may start off with surgery and then follow up with radiation or chemo, or they might start with radiation or chemo in an effort to try to shrink the tumor so surgical treatment will be more successful. So there's several different ways that this can play out. Now, for surgical treatment, I'm not going to spend a whole lot of time on surgical treatment because the reality is this is just like any other surgical patient you're going to take care of. There are a few things that I want to point out, but their post-op, all those basic post-op things still apply, even though this is a surgery related to a cancer. Okay, they're still at risk for blood clots, they're still at risk for atelectasis, they're still at risk for post-op ileus, so all those basic post-operative things that you do for every other surgical patient apply here. Things that are a little bit different here. These patients are likely coming in malnourished. I mentioned before, cancer cells have a very, very fast metabolic rate. So they are using a lot of energy. So the nutrients that your patient is taking in are being expended by these cancer cells, which is why your patient is losing weight. They are often anemic from that. If they have colorectal cancer as well, they're also anemic because there's usually some microscopic bleeding in the bowel as well. So these patients are coming into surgery in a weakened condition. Okay, so that definitely is going to play a role. They're going to be malnourished. They're coming in a weakened condition. That's going to make their post-op recovery more challenging. Okay, just because they don't have as good a building blocks for wound healing, for recovery, as somebody who's, in much better shape. Now, honestly, at this point, it doesn't matter because in this case, they need the surgery. We can try to maximize their nutrition as much as possible before surgery. We'll try to get them as strong as we can, but they need the surgery. Like this really is not an option here. So we just go with it and we have to deal with it after the fact. Okay, we got something in the chat box. Let me check that out. Okay, how exactly do you give a news briefing of a largely life-changing diagnosis like cancer in a therapeutically communicative way? Very good question. Well, first of all, as a nurse, it is not our role to be the one that gives them that diagnosis. Okay, we are not the ones that go in and say, you know, you've been diagnosed with breast cancer, you've been diagnosed with whatever. That is the provider's role. Now, that being said, it is very important that nurses are involved in that for several reasons. And this will be highlighted very beautifully in the Susie video case study, and you'll see why that's so important. But the reality is that nurse there, just the physical presence of that nurse next to that patient while the provider is giving that news is key, because somebody is there advocating directly for them. Somebody is there directly supporting them. Sometimes we don't have to say a word. Just the fact that we're present there, maybe it's our hand on their hand, maybe it's just being close by, kind of tucking in close to them, just gives them that support. Now, you know the provider's not going to be there for very long. They're going to have that initial conversation. The patient's going to be in shock. So at that point, how much of that information were they really even, you know, absorbing? Okay. It probably stopped the moment the C word came out, cancer. So after the fact, you know, when this is an inpatient and after the fact, the nurses are taking care of them, the nurses are going to be the ones to reinforce that information. The nurses are going to be the ones that are helping the patient process through their new reality. And, you know, in foundations, you guys talked about the grieving process. You know, we always talk about Kubler-Ross and, you know, in the grieving process. And we always think about that in relation to just death. But the truth is that your patient goes through that same grieving process with the diagnosis of an illness like this, with the diagnosis of any chronic illness, COPD, diabetes, anything. Cancer tends to be a little bit more pronounced because it's scary. It is very scary, you know, when we've come a long way with our technology, but the initial thought that likely goes through patients' minds is, I'm going to die. So that is a big thing that they have to work through. So, you know, with nurses, you know, what we do after the fact, once the provider has shared that information, we're helping the patient work through it with therapeutic communication. And, you know, sometimes, again, sometimes we don't even have to say a word. It's that presence. My favorite, and I think the most often used therapeutic communication technique that I use is making observations. So think about what this patient's going to be like after the doctor has talked to them. They may be crying, they may be angry, you know, just simply looking at them and saying, this is a lot. You're just simply acknowledging how they're feeling. And sometimes that can just be the opening that just lets them, you know, spill out and, you know, say how they're feeling. And it's okay for them to cry. It's okay for your male patients to cry. Okay. And supporting them and telling them that it is okay. It is okay for them to cry. And it's okay for them to feel the way they feel. They can feel angry. They can feel sad. They're going to feel that. And it's okay for them to feel that and talk to them about that. You know, we also want to encourage them as they work through this and have questions about their condition or have questions about their treatment to write those questions down, because the FaceTime that they're going to have with the physician is going to be relatively limited in relation to other people that they're going to come into contact with. So it's very important that when they do have that FaceTime with the provider, that they get those questions answered. And nurses and other people involved in the team are going to help reinforce that information. But very, very good question. You know, I can kind of give you a little story about this, and you know, but what we say really does make or break what the patient feels. You know, in this particular type of nursing, when you're working with cancer patients and you're working with patients, you know, particularly if they get to the hospice stage, it takes a special kind of nurse to do this, and not everybody is cut out for this particular specialty. and those nurses that aren't very quickly move through because they're not going to stay in a place like that. So, okay, good question on here. My dad said that when he found out it was very helpful to him, to have the nurses there to help support. Nurses gave him and my mom ways to tell the children. Should we give them ways to tell family members? You absolutely can. I mean, you can talk to them about, their diagnosis and, be like, have you, what are your thoughts about telling your family members? Not necessarily directing them, this is how you need to do it, or this is how you should do it, but start with those open-ended questions. Have you started thinking about how you're going to tell your spouse or how you're going to tell your children? Ideally, and I'm not the provider, but if I was the provider and I know I'm coming in to give this diagnosis, I would really love to do it when the patient has some family support there. Now, obviously with HIPAA, the patient has to be okay with that. But it is really not ideal to break this type of news to a patient who's by themselves with only the nursing staff. So at least, now that doesn't mean it needs to be a family reunion in there when they're getting the diagnosis, but it's very helpful to at least have a support person there when that happens. So very good questions with that. So getting back to what I was talking about with the surgical treatment, we were talking about malnutrition. So that's going to play a role just in their risk for surgery, because obviously when somebody's weaker going into surgery, they're higher risk for complications. But it's really going to be more of an issue post-surgery because it's going to delay the recovery. It's going to make the recovery much more difficult. And if the plan is for this patient to start radiation or chemo after surgery, we want to try to get them beefed up as quickly as possible after surgery before we knock them down again with the treatments of radiation and chemo. And, the reality of this is, for these cancer patients, we literally take them to the brink of death with the treatments in the hopes that we'll save their lives. I mean, that really, when you hear patients describe, sometimes the treatment is worse than the disease. For some patients it is, and that's their perception. And, some of the things that we do, we'll talk about chemo here in a minute, but they're poison, they're toxic. We're putting toxic drugs into the patient to kill these cancer cells and hoping that we can kill the cancer cells fast enough and we're not killing the other healthy cells, too many of them, that it kills them. I mean, that's really what chemotherapy is. Now, our more biologic therapies, some of the newer, the gene mapping techniques where we can kind of tailor treatments to the specific genetic makeup of cancer. Some of the stuff we're doing in research is just phenomenal. And we're seeing really good results with that, with, I don't want to say no side effects, but certainly with more manageable side effects. So I think that's where, the future of cancer treatment is going. But we are still using a lot of our classic, treatments, the chemotherapy and the radiation. And, there are side effects to that. So let's talk about chemo. And I want to be very clear for the exam. I am preparing you to be a nurse generalist, okay? A nurse generalist. You are not expected to know all the different types of chemo. In the pre-class capture, there was a chart in there and it looked at the different classifications. The purpose of that chart was mainly to show you that just like blood pressure medications, there's lots of different classes. There's lots of different classes of chemo medications. And when we talk about managing a disease, multi-drug therapy is often used to achieve the result. So that's really what I wanted you to see there, that there's lots of different options there, and it's going to be tailored to the patient based upon the type of cancer that they have, based upon the staging and the grading of the cancer, and based upon, what the overall goal is for that patient. Are we looking at palliative care, or are we, striking for a cure, that sort of thing. Okay. The other purpose of that chart if you go back and you look at it in the pre-class capture, was to list the common side effects. And as you look at them, they are all pretty similar, okay? All of them are going to cause nausea, vomiting, a lot of times diarrhea, so we worry about electrolyte imbalance. They are all going to cause bone marrow suppression, okay? Well, why is that a problem? Well, your bone marrow is what makes your blood cells. So when you have bone marrow suppression, that leads to that term, pancytopenia. That is classic of all chemo drugs, okay? So it doesn't matter what class you're giving, your patient is going to experience pancytopenia. So you need to know what that is. You need to know how to manage the different aspects of that. So for the purposes of chemo, I want you to focus on chemo just as a big umbrella, okay? Doesn't matter what class we're talking about. There'll be a couple things that I'm going to talk about in particular in relation to Susie's video, the video case study, but I'm looking at the chemotherapy drugs as a whole, not looking at a specific chemo drug. So that being said, when you see questions on the exam, it may very well have the name of a chemo drug in it. It is not going to impact how you answer the question, okay? Treat it as a chemo drug. It does not matter what classification it comes from, because the general principles are going to apply to all of those classifications. Okay, let's check the chat box. So do we need to know the class? No. Well, you need to be familiar with some of the names, although you would probably be able to pick it out of the question itself in related to, you know, the patients being treated with doxorubicin. You know, for breast cancer. Okay, what I need you to understand is it's a chemo drug. So think about the main principles of the chemo drugs. Do not focus on knowing the different classifications. Where I really want you to focus is understanding the side effects and how to manage them as the nurse. What are we doing to help manage the side effects? Are there medications to help manage the side effects? Lifestyle things to help manage the side effects, because that's really the role of the RN. We're going to be helping them manage that. We're going to be teaching them how to manage that and teaching them about their medications, okay? When you look at the different classifications, who cares if it's in the S phase or the non-S phase of the cell cycle? That really doesn't matter. Your patient knows that when we give this medication, the goal is to kill the cancer cells. That's what the goal is. Okay, they don't care what specific drugs are picked, because that's up to the provider. And again, that's going to be tailored based upon their specific cancer, the staging, the grading, sometimes the genetic makeup. Okay, so when we talk about chemotherapy, and we're going to hit this a little bit later in today's PowerPoint discussion as well, I want to really focus on the main complications. I'm just going to list them right now, and then we'll talk more about the management in a little bit. But with chemotherapy, there's an issue with nausea, vomiting, and a lot of times diarrhea. So when you think about what happens because of that, okay, well, the nausea and vomiting, first off, I'm concerned about fluid and electrolyte imbalance. Okay, if my fluids are off, I'm dehydrated, I'm not getting adequate circulation, that's going to put more pressure on my kidneys. If my electrolytes are off, that's going to affect my cardiac function. So that's a big issue there. That nausea and vomiting also affects nutrition, because if they're nauseous, they're not able to take in the nutrients that they need. So that's going to further weaken the patient when they're already dealing with a life-threatening situation, okay? The pancytopenia that I talked about in relation to the quiz, this is going to lower your patient's red blood cell count. Well, we talked about that in Unit 3. So a patient who's anemic has less hemoglobin. They have less oxygen carrying capacity. With activity, they just don't have the reserves to keep up. They're going to be fatigued. They're going to be exhausted. In severe cases, they may be short of breath with activity. You know, so that's a problem. Their white count is going to be down, which is going to make them at higher risk for an infection. And if they contract an infection, their immune system's not working to really help beat that infection. So these patients, a common cold, which is an inconvenience for us, can kill them. Okay, depending on what stage of the treatment they're at, where they are with that nadir, that can kill them. So that's a major thing. And we're going to talk about some very specific interventions related to neutropenia and leukopenia. From the platelet perspective, as their platelet count drops, they're going to be at risk for bleeding and hemorrhage. Okay, if they cut themselves, they're not going to clot as quickly because they don't have as many platelets to plug up the hole. Okay, that's a major issue. So what do we do to try to prevent injury, to prevent hemorrhage? What do we do to treat it if there's an acute problem? Those are the things we kind of look at with that. We know that chemotherapy then too is also going to cause issues I mentioned before with nutrition. So thinking about interventions to promote nutrition in these patients. Okay, and we'll talk about that. Alopecia, I mentioned it before, and when we think about the different side effects in the whole scheme of things, that's probably one towards the bottom end of the totem pole here. But the reality is chemotherapy, your patient's going to lose their hair. That can be very devastating for some of your patients. Other patients, they may not bother them at all. Females in particular, it's very bothersome, and it doesn't fall out all at once. It comes out in clumps. And, when you read accounts of patients who have had cancer and have had chemotherapy, and they talk about just kind of, a day or two, a week after, chemotherapy, they might be running their hand through their hair, and all of a sudden they have a clump of hair in their hand. And then they go to sleep, they wake up the next morning, there's more clumps on their pillow. And that is really, really devastating, because the reality is, what is the first thing you look at when you see a person? You look at their face and you're seeing their head, you're seeing their hair. And you will often find that patients that are losing their hair because of chemotherapy, they will make the decision to shave their head. And they'll make that decision because they can't control the cancer, they can't control the chemotherapy, but they can control the removal of their hair on their terms. And that is a pretty powerful thing for these patients, because they really have no control over a lot, and that just gives them that little sense of control back. So that's something we do encourage patients, to consider that as they're starting chemo, teaching them to expect that and have a plan. What are your thoughts on that? The reality is, once the patient stops chemo, once they're done with their chemotherapy treatments, that hair will grow back. It doesn't grow back exactly the same. It's usually a different texture. Sometimes it can even be, the color can be different, but the hair will grow back. And teaching them, how to use things like scarves and wigs, and just general cosmetics, because when you feel good, when you look into the mirror and you feel like you look good, that helps set the tone for the rest of the day. It sets the tone for your attitude. It sets the tone for your self-concept. And that's a big thing when you deal with patients who are experiencing cancer. And then you have the whole added piece that kind of ties into surgery. But if they've had surgical treatment related to a reproductive cancer, the removal of a breast, the removal of a testicle. I had a patient, not during the acute phase at all. I cared for him years down the road, who had had penile cancer, and his treatment was it was so advanced. His treatment was a total penectomy. So he literally had no penis, and he basically had a hole where his urethra would have come out, and he was incontinent. And you can just imagine the psychological toll that took on him, just completely devastating. So that psychosocial piece, that body image disturbance, that's a big thing for these patients. Okay. I'm going to switch to biologic therapy. Before I go there, it kind of relates to kind of in between chemo and biologic therapy. There is a kind of a separate category. It's called hormone therapy. That is typically used for your reproductive related cancers if they are what we call hormone positive cancers. So when they do the biopsy, back at the original biopsy, they also do some different testing for your reproductive cancers to determine if they are hormone receptor positive or hormone receptor negative. If they are hormone positive, they will then look to see what hormone are we talking about. Are we talking about estrogen, progesterone, testosterone? And they'll look and see that. The reason they do that is with your reproductive related cancers, they many times, not all the time, but many times are actually fed by hormones. So they're influenced by hormones. So the whole idea is if this cancer is relying on estrogen to keep it going, if we cut off its estrogen supply, that's like cutting off air to an enemy. Okay, so it's a very good treatment if it applies to that specific cancer. So just as a general concept for your hormone therapy, that's only going to work on hormone receptor positive cases. Biologic therapy, I had mentioned a little bit before. This is our kind of our new area. And when I say new, I'm talking like the last 20, 25 years. But this is where we're really starting to do the gene mapping and using these, what we call monoclonal antibodies. They're doing the gene mapping and finding like certain antigens that are on the cancer cells. So then developing antibodies that will attack those specific antigens. And what's really cool about this is if you have something that's going to attack those specific antigens, it's very targeted towards the cancer cells only. And that is a huge plus because you then don't have the damage to the other cells. Okay, so when we think about antibiotics, when we give a patient an antibiotic, it's going to affect all bacteria, whether it's a good bacteria or bad bacteria. Chemo works on the same principle that chemotherapy affects all cells, whether it's a cancer cell or a normal cell. Our goal is to affect the cancer cells, but the normal cells that are affected are the reason we see the side effects of chemo. All right, so with the biologic therapy, when they can do the targeted therapy, you're talking about targeting the cancer cells specifically with very little impact on the healthy cells. So that is really the way to go in moving forward with like future research. But we're just not there yet for all different types of cancers. And it is very individualized, even within, cancers where it's typically used. Everybody's cancer has its own individual genetic profile. So when you see like commercials on TV and they're advertising places like Cancer Centers of America and Mayo Clinic and different things like that, they don't take every patient there, but I will tell you, they work them up and they look at those genetic profiles. And if it's something where they really think that they can do something biologically to help them, that's really the way to go. It's just an awesome, way. If we can target that, let's target the enemy without having collateral damage. That's just so beneficial for the patient. Okay. Oh, good question. For hormone therapy, will they need to be on that for their entire lifespan then? It really depends. So initially, they're going to be on it. Basically, that's going to be more to block it from reoccurring, to try to reduce the reoccurrence. When we talk about treatment with solid tumors, if we can do surgical treatment, that's going to be the goal, because what we want to do is actually remove the cancer cells, remove as much as we can as possible, get clean margins around the tumor, and then after the fact, use things like chemo and radiation to try to kill off any remaining cells and keep it from reoccurring. Now, sometimes we'll do chemo and radiation prior to surgery because the tumor is really big, or maybe it's in an area that we can't quite get to very easily, so we're trying to shrink the tumor ahead of time. But the goal is really surgical treatment to try to remove the tumor, because that's going to have the majority of the cancer cells. So if we can remove that, then we can concentrate on residual cells through chemo and radiation. So very good questions, very good. So hold on to chemo a little bit. We're going to talk about that in relation to side effects. The one thing I did want to mention, is that chemotherapies are vesicant. So because of that, we prefer central line, central venous access in order to administer chemotherapy. And if you watch the pre-class capture, and if you didn't, I know if you're not a fan of my captures, I usually say that's okay. I really, really would watch this one because there's a lot of good information in there that then is going to be reinforced with Susie's case. But with the chemotherapy, because it is, you know, so caustic on the vessels, we prefer a central line. And ideally what we prefer is a Metaport or an implanted port. And what's nice about a Metaport is it's a surgical procedure to put it in, but they put it in up in the chest area. It can be on the left or the right. Usually they'll decide based on, you know, if it's a chest or thorax cancer, they'll kind of go on the opposite side. But what's nice about a Metaport is it's surgically implanted and it's underneath the skin. So when it is not accessed, it is covered by skin. Okay, so that's really nice because that skin provides a barrier infection control. Otherwise, they have essentially an IV hanging out of them the way your patients on clinical had a peripheral IV, and that puts them at higher risk for infection. So the Metaport is great. What they do when it's time for them to get their treatment, they have, you know, the skin is intact over top. You know, you do a little procedure where you kind of feel where the Metaport is, you clean the area, and we use a special needle. It's called a Huber needle, and you go right through the skin, right into the Metaport. And what's really nice about those, you can give fluids, you can give chemotherapy, you can also draw blood off of a Metaport. So that's very helpful for these patients who are being, you know, prodded and poked and everything every single day, especially if they're receiving acute treatment, or at least weekly they're getting blood work. So that's pretty cool. Because it is a central line, if you remember, we did talk a little bit about central lines back in Unit 4 when we talked about TPN before spring break. Central lines, you are scrubbing, if you're accessing them, at a minimum of 1 minute, you're scrubbing the hub. Okay, that is really, really important. It's totally sterile technique. When we're changing the dressing on a central line, it is a sterile procedure. Sterile gloves, you have a mask on, the patient has a mask on, everybody else is out of the room. We really need to be meticulous with infection control, just because of their, you know, being immunocompromised to begin with. And that Metaport, that central line, is just a direct access into the central vascular area. Okay. All right. So I want to move on to radiation. So if you pull out your radiation worksheet or radiation treatment modalities worksheet, and then we'll kind of hit this. Okay. All right. I see a question in the chat box. So let's address that. Maybe. Okay. I can't see the chat. There it goes. All right. So my mom had the port, and near the end of her treatments, it became infected. Okay, and my dad got died, chose to do IV. Infection is a risk. Anytime you have a foreign object in your body, there's always that risk. You know, you don't see it as much with the ports. I mean, if I had to choose between a port and like, you know, a basic central line, like a PIC or something like that, the port is your better option. But you know, again, you always have that risk of infection. But the port's nice in the sense that when it is not accessed, the skin is intact over top of it. So that helps provide that protective barrier. All right, so moving on, talking about radiation. And again, there's two big categories of radiation. Both of these, regardless of what we're doing, we're basically trying to expose the cancer cells to radiation and kill the cancer cells. That's what we're doing. Okay, so for external radiation, which is probably what the majority of you are most familiar with, this is where the radiation source, it's coming from a machine and it's aimed at the patient. It's very specific and targeted. the radiation, when the machine is on, there's radiation. When it's off, there's not. So the patient themselves is not radioactive. If you kind of think about this, think about the patient being there, we're lining everything up, and think about this as like a laser pointer. If I'm playing with the cat and I got the laser pointer going, think about the laser as the radiation beam. It's very targeted, it's very directed. Now, because of that, the positioning of your patient for these external radiation treatments is critical, literally down to the millimeter. More about that in a minute. External radiation is generally given daily. It's going to be a Monday through Friday treatment. They're very small doses, but they're repetitive doses, 5 days a week. And generally it's for several weeks. A lot of times it's 5 to 6, sometimes even 8 to 10 weeks. But again, it's the daily small doses, and we're using radiation to destroy the DNA of the cancer cells. And because we're doing it repeatedly, the RNA of the cancer cell doesn't really have time to repair itself because it's getting irradiated the very next day. So the goal is to kill the cancer cells. So I mentioned before that positioning is absolutely critical. Okay, so patients who are going to have external radiation are going to go through a process, what they call simulation. And simulation involves multiple scans, CT scans, PET scans, all about very precise measurements. Because based on those, they will do simulation with the patient where they position them in a way that will maximize the radiation dose to the tumor. And in order to ensure that they are positioned properly, they can do multiple things. They'll tattoo on the patient, so they're able to line up the machines with those tattoos. If it is radiation that's going to the brain, for example, this is a brain tumor, they may actually make a mold of their face, and they have this face mask mold while they're laying there to keep them in place while they're getting the radiation. It might be wedges, positioning, again, trying to line up those tattoos. The simulation part of radiation actually takes the longest. It's about 2 to 3 visits that they really get everything prepped and planned. Once they have that, and once that patient is marked with the tattoos, the actual treatments themselves, 5 to 10 minutes. Literally, it takes them longer to travel to the place to get their treatment than it does to give the treatment. Okay, so very, very quick. Couple things that you need to be aware of. The treatment site, okay, again, it will be marked with the little tattoos. So very important. We want to teach the patient, obviously they need to clean their skin, but we don't want them scrubbing at those marks. If those marks start to fade, the staff at the radiation oncology place will redraw and re-tattoo those on there. Because they are that critical. If this patient is not lined up precisely, that radiation is going to the incorrect area, and we're not going to get the result that we're trying to get. Okay, so those markings are very, very important. We want to teach them not to scrub at those markings because they need to stay. Cleaning of the treatment site, you're just going to wash over it with mild soap and water. You're just patting dry, no rigorous rubbing, no anything like that. Clothing, you want to try to have very loose fitting clothing. You don't want anything that's really going to rub on it. Breast cancer patients that are receiving radiation often find that their bra is a hindrance because it's rubbing in that area. So a lot of times they will go braless when they can, just because you don't want to have that tightness and that irritation. Radiation dermatitis, and I'm going to show this on the next slide. It was also in the pre-class capture. Radiation dermatitis will happen. It will initially start as dry and it will progress to moist. So that'll make more sense in a minute once I flip the slide. The big thing that you really pick up with this, regardless of the location, is going to be a progressive fatigue. So probably for the first 2 weeks of treatment, the patient will probably be okay. By the time they are at the mid to late stage of that radiation treatment, they are exhausted. That radiation just has cumulative effects on them. So the progressive fatigue is pretty significant. Okay. Now, on the flip side, when we talk about brachytherapy, this is internal radiation. So this involves radiation from rods, a seed, or some sort of implant that they put into the body. So at that point, when it's in the patient is considered radioactive. Now, brachytherapy can be considered high dose or low dose, okay? I'm going to start with high dose because high dose is exactly what it sounds like, high dose. So that high dose brachytherapy is given to an inpatient. This patient needs to be in the hospital. They are an inpatient. They're on a very special unit. They're on an oncology unit, and they're assigned a very specific room that is used for brachytherapy. Radiation obviously is contained by lead. So this particular room, the walls are lined with lead paint. When they develop the room, there's lead backing in the walls. The door itself has lead panels in there, okay? So everything is contained. Within the room, there are lead shields that are on, I don't know what you call them, on the ceiling when you can move stuff, how you move the curtains around. Well, not just the curtains. These are actually full-fledged panels that you can move side to side to keep that between you and the patient as you're moving around the room, okay? It's all about minimizing exposure to the caregivers that are in the room, okay? Other things that happen in that room because of the implant or whatever, and we'll talk about this in a minute, particularly for your cervical cancer patients. There is a container in there that's lead lined with tongs, because if you have an emergency where they need to put the implant falls out or something and we need to contain it, it goes into that lead lined container with the tongs. Body fluids are considered radioactive. So there's special procedures for the laundry. There's special procedures for dressings, trash, everything. Okay, so it's very specialized. Obviously, this is not the type of patient that a new grad would be taking care of. These types of patients are assigned to nurses who are specially trained and certified to do this. Same thing as a patient receiving active chemotherapy. I am not chemo certified. I can take care of a cancer patient on a unit, but I cannot actively administer their chemotherapy. Okay, so these types of things are higher level skills, they're higher level certifications. So that's why I'm preparing you as a nurse generalist, because this is not something you're going to be doing right off the bat. If you choose to work in an area like this, they're going to send you to special training, additional classes, just like they would for those of you that will end up working in an ICU setting. Okay, so with the high dose, again, the protective gear, the equipment, we have gowns that are lead lined. I have on there client positioning, and I want to talk about this particularly with the cervical cancer. How do I put this delicately? Well, what happens in 188 stays in 188. Anyway, for cervical cancer, if they're using brachytherapy, this literally is a rod. So if you kind of picture like, actually I think I have one here. If you kind of picture like a fat marker like this, okay, this is kind of your radioactive rod. And it fits into this device that kind of holds it in place, okay? And for cervical cancer, that rod is obviously inserted in the vagina and it sits right up by the cervix, okay? So obviously your patient is in a position that they can't really be moving around, or that radioactive rod is going to dislodge. So that's what I mean for client positioning, particularly for your cervical cancer patients. They would have a urinary catheter in. Okay, they would be using a bedpan if they needed to. A lot of times they'll try to, clean them out the day or so before we even start this. And they are going to be essentially on bed rest. We will have to shift their position slightly. I'm not talking going all the way over on their side. I'm talking a very slight shift with that. For the very high dose brachytherapy, you're talking hours to maybe 2 to 3 days at the max that they're doing this type of therapy. It's not going to be for weeks on end, but I need you to understand that the high dose, this is done as an inpatient. Visitor protocols for these, obviously radiation affects rapidly dividing cells. So certainly no children whatsoever, no pregnant people whatsoever can be near this patient. They would not be assigned to care for this patient. Those types of visitors are not permitted. Other visitors are permitted, but there are limits as to how close they can get to the patient. There are limits as to how long they can even be in the room. Typically, the standard is no more than 30 minutes, okay, for visitors. For staff, we really try to limit the time that they are in there with the patient. And usually they're going to change out staff every 4 hours, just simply because of the level of exposure. The staff is going to wear the dosimeter badges to kind of track how much radiation they're exposed to. These staff, like let's say you work on a unit like this and you're on for 5 days in a row, they're not typically going to assign the same nurse to this patient, you know, for the days while they're there. Again, just simply because of the exposure. In general, we like continuity of care. We cannot do that here because of the safety of the healthcare workers. Okay, so all of this really takes into consideration what I have at the bottom, the key principles, the time, the shielding, the distance. Okay, the more time you are exposed to the radiation, the more damage, the more harm that it can cause. Shielding refers to the gowns. Okay, so for example, a lot of you have had an x-ray before at some area of your body, and they put the gown over you, mainly to protect the reproductive organs. But if you're wearing the gown, you should also use the thyroid cover as well, because the thyroid is also susceptible to radiation. So that's what they mean by shielding the gown, or in the inpatient room, you know, the lead-lined walls, the lead-lined panel in the door, you know, the shield that moves around in the room. And distance. The closer you are to the radiation source, the more damage that it can cause. So in general, you want to stay at least 6 feet away from the patient. If you're coming in, I mean, because obviously you can't listen to your patient's lungs from 6 feet away. That's just not an option. So you do have to get close for that. That time that is very close should be very limited. Okay. Now, if you think about this from a psychosocial perspective, we cannot spend a whole lot of time in this patient's room who's getting high dose brachytherapy. So it is going to be very important to have alternate ways to communicate with the patient. You know, you guys have gotten to be experts at Zoom, but the same type of thing, to be able to, for that patient to have that outside connection, for us to also be able to answer a call bell to see what they need before we're going into that room. Everything needs to be planned very deliberately, because the time that we have in there is very limited. Okay. We also don't want the patient to really feel socially isolated, even though they really can't have a whole lot of visitors or anything like that, and we're not in the room for long periods of time. So we have to find ways to kind of deal with that as well. I do want to mention about low dose brachytherapy. This is commonly used for prostate cancer. They call them seeds. They'll implant these radioactive seeds in their prostate seeds. These emit a very low dose of radiation, and these are generally in for several weeks. These patients are going to be at home, okay? If you walk by them in public, they're not going to harm you. However, the same principles are going to come into play. The closer you are to them, you know, when you think about distance-wise, the more exposure, the longer time that you're with them, the more exposure. Shielding isn't as much of a big thing that we use in the home environment, but there's still a visitor protocol. If somebody's having low dose brachytherapy at home, they should not have children visiting them. They should not have pregnant individuals visiting them. Those who are visiting them should not spend a whole lot of time, you know, that whole distance as well. Spouses should really be sleeping in separate rooms during this time. So that sort of thing. Now, with the low dose radiation, generally, there's not a whole lot of special precautions for body waste. We do tell the prostate cancer patients with the seeds that they should double flush the toilet when they go. But again, you're talking very low dosing there versus your inpatient high dosing, where the entire protocol is all about containing that. And, you know, if for some reason, I mentioned the cervical cancer patient, if that dislodges, that is considered a radioactive emergency. So everybody should really be leaving the room. The radiation response team will respond. They will get in there. The whole idea is to get the radiation source back in that lead box. But that's really for the radiation response team to be doing. All right, questions about radiation at all? We've actually been doing pretty good. Haven't had too much pop up here in the chat. But if you do, put them in there. All right, so this picture, and this is one that is right off of the pre-class PowerPoint, just to kind of show you dry desquamation, dry dermatitis, radiation dermatitis versus the moist. So it will start off as dry. So it almost kind of looks like a sunburn, like a little rash, that sort of thing. So for care of that, we're just going to use mild soap and water. We're going to pat dry, and typically they're going to have them put an aloe vera on it. We want to maintain moisture in the skin. Remember, this is like Goldilocks and the Three Bears. We don't want it too dry. We don't want it too moist. It has to be just right. So we'll use aloe with that. I will tell you that your radiation oncologist will give the patient essentially just a list of products that are approved. If they are not on that list, they should not be using it. So it's going to be very specific with that. But in general, aloe is probably the #1 go-to that we're going to be using with that. And it's all about, you know, maintaining that balance in the skin. But it will initially start with dry desquamation, and then it will progress to moist. Because again, remember, we're getting radiation treatments every single day, Monday through Friday, usually for several weeks. So it's going to cause that irritation to the skin. When it opens up and it starts weeping, now we're concerned because we have a portal of entry, a potential for infection. And that's really the biggest thing that we're concerned about, because they're already immunocompromised. An infection can be deadly for them. So really taking care of their skin is important. Go back to your basic wound care principles. When it's dry, we're not putting anything, you know, to cover it. We're using the aloe vera cream to kind of keep that moisture there. Once it's open, once you have that moist desquamation, they will likely put that dressing over top of it. Now, the dressing that's chosen is going to be based on the actual wound condition. If the wound has lots of moisture, there's lots of exudate, we want a dressing that's going to help absorb that. Okay, if it's not, then we're going to use a different type of dressing. You want to have, you know, that just right amount of moisture to help kind of promote wound healing. Although I will tell you, this wound is not going to heal as long as they are continuing to get radiation at that site. So at that point, it's trying to keep the skin intact as much as possible, reducing the risk for infection, and then promoting the healing once the radiation therapy is finished. But it's kind of gross looking at it. All right, so if you pull out your worksheet that you had to do for the growth factors, the CSF medications, these are pretty important because they're going to address the side effect of the pancytopenia. So there's one for each cell when you think about it. So for your red blood cells, and we've talked about this in Unit 3, this is your procrit, this is your erythropoietin. It's going to stimulate production of red cells in the marrow, just like we talked about in Unit 3. Big side effects, hypertension, and increased risks for your cardiac events, your MI, CVA, and the DVT. Okay. Dosing is generally sub-Q. This is given not only to cancer patients, it is also given to patients with kidney disease. Because if they have kidney problems, the kidneys aren't making the erythropoietin, which then stimulates the production. So you will see this given to patients who are non-cancer patients. So the dosing is going to depend on the underlying reason why they're on it. And it's also going to depend if they are a dialysis patient, they're likely getting it 3 days a week versus the 1. From a nursing perspective, very, very important to monitor their blood pressure, because if it's going up, that puts them at risk for those cardiac events and increased risk for hypertensive crisis. Our goal is to get their hemoglobin 10 to 11. Yes, I know that is still low, okay? But remember, we're not using this for a patient who is very mildly anemic, okay? We are using this for significant anemia. If they are below 10, this is something we're likely going to use, particularly for a cancer patient. Okay, all right, I see something in the chat box here. Oh, my chat box isn't coming up. Okay, I'm gonna keep going until it appears. Sometimes it just pops up all by itself. So our next one, when we look at filgrastim or Neulasta, this is specifically to stimulate production of the white cells in the bone marrow, okay? This we use for our chemotherapy patients, but it's very important. The timing of the dosing is critical. You cannot give it until 24 hours after the chemotherapy treatment because the chemo is still in the system and it would basically be a waste of the injection. It is given sub-Q and it's dosed the 24 hours after the chemo treatment. When you watch the video case study, this was one of the medications that was part of Susie's protocol. And this was huge. This literally probably kept her from dying from an infection during part of her chemotherapy. Side effects, anaphylaxis is a big one. So when they give that shot, especially the first time, usually all the times, but particularly the first time, they're going to keep the patient in the office for about 20 to 25 minutes just to make sure they're not experiencing an anaphylactic reaction. The other big side effect of this is going to be bone pain because it's stimulating production in the bone marrow, which then results in bone pain. So pain management is going to be very important for these patients. They also have pain related to the chemotherapy they're actually receiving. So in regards to pain management, they may start with your acetaminophen and your NSAIDs. Many times your chemotherapy patients are going to be on narcotic level, opioid level pain medicines. Splenomegaly is also a concern. Doesn't happen all the time, but if your patient starts reporting left upper quadrant pain, which is where your spleen is located, that's a priority. That's something that they need to call the provider about right away. If you notice it as the nurse, it's something you need to call the provider about right away. Obviously, we're going to be doing weekly monitoring of their CBC. We're looking for an increase in the white count overall. We're looking for an increase in the neutrophils, and obviously we want them to not have an infection. So if we're looking to see, you know, is it effective, that's what we're evaluating. Our last one is going to be opravlocin, and this one stimulates the production of platelets. Now, if you look at your normal lab values, and just a reminder, it would behoove you to look at those lab values for Monday for the quiz. That could be very important. Your normal platelets are 150 to 400,000. These we don't start actually using until the platelets get below 40,000. And when we use it, our goal is to get the platelets up to at least 50. Now, that is still significantly low when you look at the normal range, but we don't use this unless it's getting pretty critical, okay? Again, we're always looking at the benefit versus the risk. Anytime your patient has lower than normal platelets, yeah, they have an increased risk for hemorrhage, but there are risk side effects of this particular medication. So the benefit of this medication does not outweigh those risks until we look at a very significantly low platelet count. Again, anaphylaxis is a concern. Fluid retention is often a problem with this. And it will cause fluid retention and swelling in the eye tissue. So they'll get papilledema and they'll have blurry vision and just difficulty seeing. This is also associated with cardiac dysrhythmia. So some pretty serious stuff, which is why it's not one of the first things that we use, okay? We don't start this medication until it really becomes an issue for the patient. We will be doing things before that to reduce their risk of bleeding. But once they get below that 40,000 mark on their platelets, their risk of hemorrhage is really significant. So at that point, you know, we now need to do this. This is daily sub-Q dosing. Again, the life cycle of a platelet is 5 to 7 days. So they will monitor their CBC weekly. And again, our goal is to get that platelet above 50,000. Okay, so here's where I really want to spend the bulk of the time that we have left here. And I know we're going late, I know we're going long, sorry, but this is good stuff. It's good stuff. With pancytopenia, obviously we have the medications that we just talked about, but I just want you to think about this from a basic functional level. And let's start with anemia. Let's start with the red cells that we had talked about before back in Unit 3. You know, if your patient is anemic, they don't have the capacity to carry enough oxygen. So they're going to be fatigued. They're going to be pale. It may very well be appropriate for them to have supplemental oxygen. They do need to stay active. Now, I don't mean active as, you know, we're doing aerobics, but if you're laying in bed and you're completely immobile and very limited, you know, mobility, there's risk to that too. So your anemic patient, it's really important that they do continue with activity. Now, it has to be very deliberate and it has to be very spaced. I'm talking maybe just going to the mailbox to get their mail. Maybe just walking from, you know, their chair or bed to the bathroom and back, but doing that frequently. They need to be up and moving every day. It's helpful to try to set a time, you know, like a basic routine for them. So like every day at 2 o'clock, I'm going to go out and walk to the mailbox, or every day at 2 o'clock, I'm going to do, you know, a lap around my kitchen. Just very specific and deliberate. They do need to take frequent rest periods. Obviously dietary, you want to make sure you have decent nutrition to at least provide the building blocks for those blood cells to form. But that's really what we're looking at from an anemic perspective. If their count goes extremely low, that procrit's not going to be enough, and we're going to need to transfuse this patient with packed red cells. So the stuff we talked about in Unit 3 related to blood transfusions absolutely applies. If we switch over to thrombocytopenia, okay, low platelets. Again, we're not going to start the medication therapy till we get our platelets below 40,000. Now, there's a lot of room between 40,000 and the 150, the bottom end of normal. So we want to make sure we put these patients on what we call bleeding precautions. So we want to limit any type of activity that is going to increase their risk for bleeding. So obviously an electric shaver would be appropriate. No straight razors with the shaving cream, not happening. For toothbrushes, definitely soft bristled toothbrushes. As the platelet count drops, maybe even moving to swabs. Definitely no dental floss, okay? Particularly when the platelet count gets low. They have that dental floss, they're up there, and yes, that gets stuff out from under their gums and stuff, but it causes microscopic cuts in the gums. And if they don't have adequate platelets, that's going to cause significant bleeding. So these are the patients who really should not be flossing, okay? Just saying. But certainly, obviously, no contact activities. You want to be very careful when you're moving these patients, because if they bump into something, bruising, bleeding is going to happen. We want to avoid procedures in these patients. So I would not want to do any type of rectal temp, rectal suppositories. I want to avoid IV sticks as much as possible. I want to avoid injections as much as possible, because again, this is another trauma that can cause bleeding to the patient. For leukopenia and neutropenia, these are really serious. And again, you know, when I mentioned the nadir, that's the time that those counts are the lowest after chemotherapy. So that's 10 to 14 days after chemotherapy, where those counts are going to be the lowest and they're going to be at the highest risk for infection. So start with your basic stuff that we do for everybody. Hand hygiene. Okay, obviously, if you're sick, you don't want to be around these patients. They should be avoiding people who are ill. anybody who's been recently exposed to an infection, anybody who's been recently received a live virus vaccine, your MMRs, your varicella, those things are live vaccines. They shed for a couple weeks. These patients should not be around those individuals, okay? Very, very important. As that white count drops, we then also need to take additional precautions. So certainly PPE. You know, when we think about gown, gloves, and mask, usually we wear those to protect ourselves from the patient. My patient has TB, my patient has COVID, my patient has C. diff, my patient has MRSA. I'm wearing that stuff to protect myself and the other patients because I don't want to transmit it. These patients, this type of isolation, it's called simple protective isolation. It's also known as reverse isolation, neutropenic precautions. There's like 5 different names for it. Now we're wearing the PPE to protect the patient from us. We are the threat to the patients, at least from an immune perspective, okay? So it's very important to kind of understand that, you know, what is the purpose of this PPE? And now it's not for us, it's for us to protect that patient. So if your patient's on neutropenic precautions, they're going to be in a private room. They're gonna have all that PPE that everybody has to wear going in there. Visitors will be limited. If anybody is sick, that is not happening. They are not going in that room. Meal tray wise, everything needs to be in its own container, preferably prepackaged. Even the bread that they use, they have individual slices of bread that are prepackaged inside cellophane. Bottled water, they cannot have water that sits out for a period of time. If they have a bottle of water, generally it's going to be good for a couple hours. That's it. You know, 4 hours, then we replace the entire bottle. We don't let those styrofoam cups that tend to sit on regular patient trays for a while. On their meal tray, all their food needs to be fully cooked. They cannot have raw or undercooked foods. Fruits and veggies, raw fruits and veggies are a no-no, just because of the increased risk of bacteria. When we cook food, it's going to kill bacteria, potential pathogens. That's why they have to have fully cooked food. No live plants in their room. Absolutely not. Just not happening. Usually when we talked about visitors, no children are coming in to visit because, not to be rude, but children are germ factories. They just absolutely are. And it's a risk to this patient. Trying to think of other stuff, equipment in the room, anything that might have moisture in it. You know, you think about your respiratory equipment, your oxygen tubing, nebulizers, you know, incentive spirometers, anything like that. Those actually get replaced daily. Okay. In general, in the hospital, they're replaced weekly. That's part of the protocol. These patients, because you have the risk of the bacterial and pathogen growth because of the moisture in it, they get replaced daily because of their neutropenic status. So when you talk about a patient being in, you know, simple protective isolation, that is critical. So, you know, when we think about a normal white count, your patient's white count is going to be low. That doesn't mean that every single patient is in reverse isolation. If their white count gets below 2, if their neutrophil count gets below, like the absolute neutrophil count below 1, below 0.5, they are going to absolutely be in reverse isolation. So as a nurse, it's very important for you to know, even if you're not a cancer nurse, if you're not a chemotherapy nurse, if you're taking care of a patient who has cancer and is receiving therapy, they're getting chemotherapy periodically, you want to know, when was their last treatment? Because if it was 10 to 14 days ago, you are hitting them at their nadir, and that's when they are most vulnerable. Okay, so that is really, really important to know when that last treatment was. All right, so that kind of hits the stuff that we were talking about for the pancytopenia. For the malnutrition and the stomatitis, I put that together because they really do go hand in hand. Now, the malnutrition can also be related to nausea, vomiting, diarrhea, but most of the time it is because the patient's oral cavity is just so inflamed. It gets this, they develop mouth sores in there. that are so painful. Even moving their mouth, talking, swallowing, trying to take a drink just causes excruciating pain. So they don't want to eat or drink. That obviously is going to contribute to malnutrition. Plus you have the fact that the cancer cells are using up that energy much more quickly than your normal cells. Okay. So a couple things with this. From the malnutrition standpoint, obviously we want high calorie, high protein, high good fats in their diet. We need every single bite that they put in has to maximize the nutrients that they're going to get. We want soft, easy to chew foods. We want things that are generally going to be like a room temperature. You don't want things that are really hot. You don't want things that are really cold. They're not going to tolerate those really well. The other thing that can contribute to malnutrition is a change in the taste of certain foods. That can definitely really turn them off from eating. A diminished appetite is very common in cancer and chemotherapy patients. That's actually was the beginnings, the very early beginnings of using medical marijuana for cancer patients, because it actually it helps with pain control, but it actually stimulates their appetite and makes them eat, gives them the munchies, which for your cancer patient was a very positive thing because we were trying to maximize their nutrition. Getting back to the stomatitis specifically, obviously we use pain management with that, but we will actually use something specific. It's called Magic Mouthwash. And it has some different things in it, one of them being lidocaine, and they basically do a swish and spit before meals, and it helps numb the mouth. So they don't want to swallow, because if you swallow it, it can help numb the gag reflex, and you don't want to do that. So it's a swish and spit, but it numbs the oral cavity, so they're able to take in some of that food and drink that nutrition. So that Magic Mouthwash is pretty important. And Susie will talk about that in the case study because that was part of her protocol. Fluid, electrolyte, acid base imbalance, the nausea, vomiting, the diarrhea. Before I get into that piece, but with the diarrhea, you can also see skin breakdown in the perianal area. Obviously that's uncomfortable, so that's a major thing. We're really kind of doing better with this because nausea is a very common side effect of chemotherapy. So what we are starting to see, not starting to see, this has probably been going on probably the last 10 years or so, that we are being proactive in medicating these patients even before we start the chemotherapy. They will have their chemotherapy drugs, but before that, they'll have what we call the pre-chemo cocktail that often involves some pretty powerful antiemetics. It might involve acetaminophen, some additional fluids that we give, IV, all to try to counteract the nausea and the vomiting and essentially the hypovolemia. So what I want you to understand with this is we are going to pre-medicate. The number one class of medications are going to be your ondansetron, your Zofran, and related medications in that class. They work very, very well for chemo level nausea. And they are going to be dosed IV prior to chemo, and these patients will have prescriptions for these that they will take them after the chemo, sometimes even around the clock, just to kind of battle and keep this at bay. You'll hear Susie talk about this in the video. When she started her treatment, it was 2010, and we were not as proactive in medicating ahead of chemo, at least the first time they had chemo, because we kind of wanted to see what their body was going to do. We don't want to give meds if it's not necessary. We are much more proactive now. So you'll hear her talk about her first chemo treatment. She didn't have anything ahead of time. For the remainder of her treatments, she did. They pre-medicated her. For the body image disturbance, I did talk about that a little bit previously. With, helping the patient come to terms with that, shaving their head, selecting scarves and wigs and that sort of thing. But just acknowledging the fact that they're different and they feel different. And especially if there's been surgical treatment where they've lost a body part, you know, a breast, a testicle, and how that really affects their identity. You know, every time I look at this particular topic, it reminds me of a scene out of Aaron Brockovich. And if you've never seen that movie, now's not the time, you're busy, but sometime this summer, watch it. It's about a lawyer who helps litigate a case related to contaminated water, a utility company contaminated water. But one of the people, one of the citizens that was affected by the cancer, you know, she was diagnosed with tumors in her breast and tumors in her uterus. And she made the statement in the movie to the main character. She says, well, they're not, I guess they always came up benign, they're not. And she said, if I have no breasts and no uterus, am I still technically a woman? And when you think about that, I mean, obviously genetically she's a woman regardless, but you know, how much of that really is part of that individual's identity? So that body image disturbance, it's not even, you know, it's not just the loss of that part, but it's the loss of the identity of the person that they were, the person that they were prior to this diagnosis. You know, so that's a huge thing. And again, it goes back to, you know, therapeutic communication. I mean, I haven't been there. I don't have a mastectomy. I can certainly empathize with them. I don't know how they feel. What I can do is acknowledge their feelings, tell them that it's okay to feel that way, and encourage them to talk about it. And sometimes if you can link them up with somebody who's been there, that's a huge thing. You know, that's a huge thing. I can tell you stuff out of a book. I've never been there. Never been there. So, you know, if you can have them, you know, link up with somebody, that can be very beneficial. The other thing is, don't forget the family members and the spouse, because as awful as the patient is feeling, the spouse is feeling some of that as well too. I mean, there's concern there in the sense of, you know, the health related, you know, status of their partner, but also not wanting to upset their partner. And, you know, how are they going to react the first time they see their spouse missing a breast, you know, or, you know, with one less testicle, you know, and how that ties in with that. So it definitely is something that impacts the couple. So encouraging them to, you know, talk separately, but also talk to each other through that so they can support each other. With pain management, sorry about that. With pain management, obviously we always want to try non-opioids first. When you talk about cancer pain, a lot of times we're at the opioid level. So typically what we like to do is use long, you know, extended release opioids to try to maintain a level of analgesia in their system all the time. And then we'll use short-acting breakthrough medication. This is especially true as patients progress to the terminal stage, the hospice stage. It's just very important to try to keep their pain under control. And just like we do with post-operative patients, where we use things like Tylenol and Ultram around the clock, and then just use the opioid for the breakthrough pain, it's the same concept. But usually with these patients, the long-term is usually the extended release opioid, and then the acute is the short-term, the immediate release opioid. But that's really important for pain management. The other thing that's important is to augment that with your non-pharmacologic pain management strategies. So, you know, they're certainly not a substitute, but if we can use that to enhance the pain control in a patient, it's definitely appropriate. So, all right, so all that for an NCLEX item. Upon review of morning labs for a client receiving chemotherapy, again, it doesn't matter what kind, they all cause bone marrow suppression, which intervention is priority? So go ahead and look through your labs there, look through your options and shove it in the chat box. What do you think is going to be a priority? Okay. Now we probably, remember, if it's a priority question, we're likely going to be doing all of these, but which one, if you could only do one, Which one's going to be the most critical for your patient's well-being? And I'll give you a minute and you can throw them in the chat box and we'll take a look. I think people must be looking up their labs right now because there's nobody in the chat box yet. No brave souls in the chat box. No, don't look at that. Okay. All right, well, I'm not going to take forever here, so we're just going to work through it. So when you look at these values, right off the bat, I can tell you the white blood cells, the red blood cells, and the platelets are all low, okay? The creatinine is actually normal. So if you look at your interventions down there, there's one related to white cells, red cells, and platelets, and there's one related to creatinine. The creatinine one is D, and this would be used for, avoiding that extremity if we're thinking this patient might require dialysis at some point. Since the creatinine's fine, I can eliminate D right off the bat. So I'm left with A, B, and C, and they all relate to your white cells, red cells, platelets, this pancytopenia. So they're all low. So now you need to ask yourself, okay, they're all low. I expect that in a patient with chemotherapy, but which one is low enough that which one is the most life-threatening to my patient? Okay. So your white count, your normal white count starts at about 4. Well, I'm 2.7, so I am low. I'm not low enough that I need neutropenic precautions. I'm not below 2. My neutrophil count's not down severely. So I still want to do infection control, but do I need neutropenic precautions quite yet? No. So I can eliminate A. Okay. My red blood cells, 3.8. Okay. Well, we like it to be in the mid to high 4s. Okay, so it's down, but is it critically down? Okay, in general, when you're looking at this, your hemoglobin is usually going to be 3 times your red count, and your hematocrit is going to be 3 times your hemoglobin count. So I don't have the hemoglobin in front of me, but I know with a red count of 3.8, my patient's probably in the 10s for a hemoglobin. So that's not critically low. There's no indication that she really needs oxygen right now to maximize that because her hemoglobin isn't critically low. So I can eliminate C. So I'm thinking the answer is B. I want to confirm that with my platelets. Oh, 30. Okay, well, right off the bat, I know that my normal platelets are going to start at 150. So now we are significantly low. So this patient has a critically low platelets. So now I'm worried about hemorrhage. If they're going to bleed, we get concerned about spontaneous bleeding in the GI tract. So that's why I'm going to focus on B, because that's going to indicate if there is a problem with hemorrhage. So working through that, the correct answer is going to be B, because that one is the most life-threatening at this time. Now, I'm going to take it back for a second. As you know, in my spare time and in my little devious mind, I like to write NCLEX questions. It's fun for me. So as you look at this question, I just want you to think about this, because this really is 4 questions in one. If the lab values were different, if the platelets were 130 and that white count was 1.7, then A becomes the correct answer. Okay. If the platelets are higher, the white count's the same, and the red count drops significantly, then C is your priority. So I want you to understand, and the reason I point this out, this is why knowing your lab values is important. And it's also why reading the question carefully is very important, because literally I can get 4 different questions out of this particular one that's right there on the screen. Okay, so it's very important to identify those keywords, and part of the keys in this particular item, or these types of items, are what the lab values are. Okay, so I just wanted to emphasize that. That's very, very important. Same thing when you were looking at NCLEX questions before. Which statement indicates understanding of the teaching? Which statement indicates further teaching is needed? Okay, just very important to, read what your, question is asking. All right, so where do we go from here? So we went over a lot today. So you should be able to go through fairly quickly the U6C3 online class worksheet. Now that does relate back to two of those Hinkle interactive case studies. One is prostate cancer, one is breast cancer. So you will need to go through those as well. But I think the rest of the stuff we kind of really covered. So you need to complete the online class worksheet, and that goes to the Unit 6 Class 4 Prep Dropbox. That is part of your quiz, okay, for Monday. So you have to do that. And the reason I made that mandatory and part of the quiz is because it really helps prepare you for the video case study, okay? If you do not upload the online class worksheet, you will not be able to access the video case study, okay? Even if you upload it late, that will then allow you to access the case study, but you have to upload that in order to get to the Susie video, okay? Also, the quiz on Monday focuses on lab values. I reposted that lab value reference sheet that I gave you hard copy earlier in the semester. It is posted on U6C4, or maybe it's U6C3. It's on there. So please use that to help you. Okay, very important. Then on Monday, we do not have a scheduled Zoom session. I allotted you that time to watch the Susie Phillips video case study. You can watch it before that as long as you've uploaded your class 4 prep. Okay, it'll let you do it. But I allotted that time for you to watch that video. The video is approximately 1 hour and 15 minutes. It is just a video of Susie when she came and spoke to a previous Penn College class. The video quality, like the vision quality, is not the greatest, but that's okay. What I really want you to get out of this is hearing her story and hearing the concepts that we talked about today and how it applied to her. Essentially, seeing cancer in the flesh and hearing her experience, because her particular case ties in almost everything we talked about today. And it just really kind of puts it into perspective and really solidifies the concepts. So I want you to watch that. Now, during the video, when she came and spoke to the students, she had some handout. It wasn't a handout, but it was like some pictures there. I don't have access to those. When she came, it was about 8 years ago. And although it's been 8 years, the quality of her story and how it touches and all the content is still applicable, which is why I still use her case study. Seeing the things that she's referring to is not critical to understanding what was going on. There is a document, it's called an accompanying worksheet, that goes along with the case. And there are questions specifically related to Susie. I want you to fill that out. You can jot some notes as you're watching the case. You can fill it out afterwards. But that's going to be the basis for our discussion about this case. And there's the Zoom session that's on Thursday. And I know this is a different date. It's Thursday, April 30th, same time, our 12:30. And the purpose of that is going to be to discuss the case and the worksheet. And then, of course, to answer any questions that y'all have, before the exam. I am still going to have the exam review prep session Friday morning like I've been doing prior to the exams, but this one for Thursday is going to be specifically related to the video case study. I will be recording that as well. That will be uploaded to the class YouTube channel if you're not able to attend. Obviously, live is always best because it gives you the opportunity to ask questions in real time. So that is kind of the agenda for that. So I'm gonna stop sharing my screen now. Okay, now I can see the chat box. How wonderful. Okay, all right. So let me come back up here and address any questions. Does the radiation irritation increase the risk for cancer itself? That is a very good question, because radiation exposure is a risk factor for cancer. Realistically, somebody that has had cancer, that is treated with chemotherapy and radiation for that cancer, they are at risk for the development of secondary cancers later on. So that is a concern, but the reality is, if we don't treat them now, what's more life-threatening? A potential cancer down the road, or the current cancer that they have? So we're looking at the priority of dealing with this right now. Is it the cancer that causes the pain, or the chemo radiation? It's actually both. The cancer itself can cause issues with pain. Chemotherapy can be painful. There's certain types that can cause a peripheral neuropathy that causes just a very severe numbness, tingling, pain down the legs. And that's one of the things Susie will talk about in her case study, because that is something that she experienced. The other thing that I didn't mention that is kind of important to keep in mind with the chemotherapy treatments is these are poisons, these are toxins. So we're putting them into the body. They do need to be metabolized and excreted by the body. So these do increase the risk for liver and kidney problems. So obviously, watching liver function tests, watching renal function, maintaining hydration in the patient is going to be critical, just trying to help protect those kidneys. There are also certain ones, and I'll mention this one in particular, mainly because Susie's going to talk about it as part of her treatment regimen, but adriamycin, which is the brand name, it's known as doxorubicin. That is a very powerful chemotherapy drug that is known to cause cardiac toxicity. So there's actually a lifetime limit on the amount of adriamycin that a patient can receive. And they will monitor these patients with EKGs, echocardiograms, to monitor the effects. I had an acquaintance a couple years ago who was pregnant at the time she was diagnosed with breast cancer, and her breast cancer was very aggressive. Obviously, when you have a developing fetus, there's the question of the effects of the chemotherapy on the fetus. At that point, when she started chemotherapy, she was approximately, I want to say, 5 months along in her pregnancy. So the initial formation of the fetal structures was already finished. But they did treat her with a lower dose. One of the things she received was the adriamycin, and her baby was born. Everything was fine with the baby, but he is monitored by a pediatric cardiologist because of potential cardiac effects on him as he grows. So that is something to consider, that some of these medications are going to have some potential damage to the organs. So again, sometimes we are taking them literally to the brink of death with the hopes that we will save them. So watching Susie's case, I think, is going to be very powerful for you guys, and it will really help really solidify the concepts that we talked about today that you've been preparing for. And that's why I continue to use her case. So, all right, any other questions? I think I addressed everything in the chat. If you have any last minute questions, please feel free to put those in the box. Okay, this PowerPoint will be available. Just the PowerPoint that I showed is actually already posted up on Plato now. Of course, the Zoom recording, once it's processed, that will go up on the class YouTube channel as well. So I don't see any other questions. So happy Friday. Enjoy your weekend. And I won't see you on Monday because you'll be watching the case study, but do reach out if you have any questions. And if not, I will see you next Thursday in our discussion.